Next presentation is also fascinating, and really the next presentation is truly, in my opinion, the future of medicine as we see it. Although, as you very well pointed it out, we should never lose the wisdom that was passed on to us by our culture and by generations of healers like meditation and pranayama. Topic today is exosomes, and this is really something that I've been doing since the 2000, right around COVID time, and it is something that will be figuring more and more. I see more and more companies involved in it, which unfortunately has two issues. One is it brings a lot of people who are trying to make money unscrupulously on the hype that is generated by this exosomes, which in the past 20 years were thought to be simply garbage, a byproduct that the body excretes, but are now found to contain the elixir perhaps of longevity and life. So again, thank you for the opportunity to share with you our experience, and we're going to present the three case series of patients that have a different type of wound and the use of exosomes to try and heal it. So let's get with the first case. And this is a physician, actually. He's a pain management doctor who had a squamous cell carcinoma on his back. I have the picture of it right now, but it's on my phone, the last picture, which showed that in less, yes, and I can share it here, and you can see that in less than 30 days, the wound is completely healed, and I'm not showing it stretched. It's on my phone in a stretch mode, but it's really reduced in size. Today is the May 27th, and you can see this picture is 21 days afterwards. And you can see it's mostly granulated. There are a couple of wounds over here, superficial, but this was down to the fat, and you can see here it's practically closed. Now it was really, really large, 8 by 5 centimeters, and of course I could have closed it by a flap, by a graft. But this doctor is constantly sitting, standing. It will be very, very difficult, and the likelihood of that graft surviving or that flap not dehiscing was very low. Included with that would be the idea that it would be painful and restricting his movement. The interesting thing, and I'll tell you later, what I did not expect is by me simply injecting it intradermally, or in this case into the fat and the surrounding tissue, I was able to help his back pain. So this pain management guy had a 4 months history of back pain, for which he tried NSAIDs, muscle relaxers, and physical therapy. He did not try steroid injections because he was worried, he was unsure what is this lesion on the back of his thigh. And he said, the funny thing is, and he said it himself, I didn't ask him, I tried all those things, nothing really helped for my back, and yet it got better, not 100%, but around 70% better after you injected me with the exosomes. So the exosomes are extracellular vesicles, and they travel way beyond the area where you inject, which can have positive and potentially other consequences we have to keep in mind as we're learning about those amazing small little particles the size of the COVID virus. So let's understand first wound healing. Wound healing goes through 3 phases that are not really divided. They are all combined together. It goes through the phase of clot formation, then the inflammatory phase, which makes sure that they fight the bacteria, and then the collagen formation, where the fibroblasts produce the collagen, elastic tissue, and try to form the scar tissue again, which actually gets remodeled with it too. Let me just move this. And this is the third phase. What are the challenges with wound healing? Well, you can have always overgrowth of bacteria in the area. Most commonly is the staphylococcus. So the skin has an acidic mantle. The pH of the skin is around 4.5. When it's wounded, it loses its pH and it becomes a little bit more neutral pH. We know the blood is pH of 7, neutral pH. And when the pH is around 7, bacteria start clinging into it. Even bacteria that are not pathogenic start entering the wound. And you can actually see it in measurements of the pH of the wound. When it gets a little higher, it actually slows the healing process. And so you have to bring the pH down, and you have to make sure that it doesn't get super infected. Other things like oxygenation, the location of the area, the tension on the wound, comorbid condition like diabetes, cardiovascular disease, all those things may contribute to the speed or the slowness of the healing. A few of the techniques of wound reconstruction, their pros and the cons. You can do it as a primary closure. It's either intermediate, complex, or just straightforward. And it's a simple thing that you can do. The downtime is usually about a month. You take out the sutures depending on the location, anywhere from 5 days in a younger person to about 2 weeks on a trunk of an older person. Pros could be that the sutures may speed. A flap is a more complex procedure that you would do that would move the tissue around the area. It requires multiple additional scars that you have to do in order to move the tissue. It's a little more intensive in terms of the technique that you need to know, and the healing time is a little longer, about a month to 6 months. A graft can be either full thickness skin graft, which matches better to the normal area, especially if you take it from that region, or it could be a split thickness, which is very often used for burns. The problem with those things is they do not contain the appendageal structures of the area, and they don't match very well. They contract, they look like a burn scar, like just a thin paper skin that you put on top that does not look good. And they usually also have contractures, so it requires a lot of healing afterwards, physical therapy, massage, maybe steroid injections and things like that. So it's really a lot of downtime, and the problem with that is probably the issue with the remodeling. And then there is secondary intention healing. Now, I do Mohs surgery, which is controlled skin cancer removal, where you examine the tissue edges right away under the microscope and then suture it or allow it to heal by secondary intention. And you saw this gentleman with the 8.2 by 5 centimeter big lesion on the back of his thigh that I allowed to heal by secondary intention. Although with the aid of the exosomes, and you saw how it healed, I saw him today, it looked even better than it looked on the picture when it was 21 days ago, which was a week ago. The secondary intention can heal beautifully, even better than stitches, in concave areas. So if you go, for example, in medial canthus, it is a beautiful area to heal. But other places, it will actually cause contracture. It can pull the eyelid down, lead to ectropion, and cause the scarring around joint spaces and reduce mobility. So what can we do to try and speed it up? Well, there's a lot of stuff that has been used. I'm just showing a couple of those things that I've used in the past. I have not used naloxone, although that is also being used right now for speeding of the wound healing. This is just a beta blocker, bimatopros, that can be used as eye drops, but in this case we're using it to speed the wound healing. Medihoney, because of its antibacterial effects, perhaps some other reasons, it also helps the healing, but it is very, very sticky. They also have it in sheets. Allografts are what you use from substitute for skin, and that is taken from placenta or other forms. It doesn't have any allergy. You have to replace it once a week. The problem with that is in some areas, as I'll show you in one of the cases, it does not hold on, and it can fall off, and it's very, very expensive. We're looking, depending on the area, at a cost of around $10,000 per application, sometimes even more. At least that's the cost in the United States. And the way they do it is they dry a certain part of the placenta or other substitute of the skin, and then they give it to you in the sheet. You wet it most of the time and apply it to fit the wound that you have. And it has some growth factors as well on it that allows the wound to heal. Then you cover it, and the person cannot wet the area for an entire week. The other issue with that is sometimes they get super infected, and unfortunately that has happened with some of my patients as well, and you have to replace it. Regronex gel, I've been using it a lot, very expensive. As a matter of fact, one of the patients that I recently saw said that he had to pay $1,700 in the US to get it. The insurance did not cover it. Although when insurance covers it, although it's still a burden on our economy, it could be a copay of $30 or so. Hyperbaric oxygen, well, multiple sessions are required for that. It definitely works. It speeds the healing time, but people who are claustrophobic cannot really utilize it, and I've tried for some people and they simply said forget about it. The other thing is it can cause some popping in the ears, a lot of compression. It's kind of like going into chamber where you underwater, and so you can feel the compression in the ear, and you have to slowly increase the pressure, usually to about 2 atmospheric pressures, and you have to go 5 to 4 times per week for a period of 2 months for the area to heal. So we're going to talk now about exosomes. And exosomes are non-immunogenic, fast-acting, and you can use them either as injection, application, IV. You can drop it into the mouth through droplets, or massage it into the area. And this is really the key for the regenerative medicine nowadays. So let's look quickly at the structure. It's a lipid bilayer structure, and that's very important. Why? Because we talked about the pH of the wound. If the pH of the wound is going to be too acidic or too basic, it will go ahead and destroy this beautiful lipid bilayer, which is very sensitive. And while it can handle lower pH of about 4.5 or so, lower pHs than that will destroy the cell wall and prevent its ability to use those special receptors. It will prevent those receptors from being present on the cell wall and therefore docking in the area that they need to be docking to. So this will just be like applying Regranex gel, which is only the platelet-derived growth factor beta, as opposed to all the other growth factors that I'll show you shortly and that Sophia prepared for you to see. So let's go to the next area. Where is the best exosome being taken from, and what are they utilized for? Well, the richest and most productive region to get the exosomes, and we call them H0, and that's the company that I personally use. I do not work for them. I have no personal what they call benefit from it. Is the wharton jelly, which surrounds the blood vessels, the umbilical vein, as you can see over here, and the 2 arteries. And that area is really the highest concentration of the mesenchymal stem cell derived exosomes. And so this area is harvested, centrifuged, and the cells are collected from that area, and the size is very important also. The size is about the COVID virus size, 50 to 150 microns, and they are then conserved without any antibiotics, without any added factors into it, in a special minus 196 degrees, so it's like liquid nitrogen, special huge canisters, and there it can be stored for years, 2, sometimes more years. I personally store it in the minus 40 degrees because I do not have the ability to store it in liquid nitrogen. You would need huge storage for that. So it can lead to stem cells. Stem cells obviously can lead to bone, adipose tissue, nerve regeneration, cardiac regeneration. And so, as I said, exosomes truly are the future of medicine. Learning how to control where they go, what they produce, would be our next stage. And perhaps even now they're working on trying to use those as little messengers that would carry immunotherapy or chemotherapy into the tumor by using them as a docking to dock and be internalized by the cells that you want to either heal or kill. Exosomes are usually found in MVBs, which are the large vesicle you can see over here, which contains many of them. And this basically shows how it contains all the different parts in it, the different growth factors that then later invaginate and are released into the cytosol, into the surrounding tissue. And using those little honing factors, they would be pulled into or attracted to wherever the inflammation, wherever they sense there is an SOS signal that would need their assistance. And these are the different growth factors that are found in the exosomes, and there are many of them. This is just some of the growth factors specifically found in the mesenchymal stem cell derived exosomes taken from the wharton jelly of the umbilical cord. And you can see here VEGF, TGF beta, all of them reduce inflammation. They reduce scarring by its anti-fibrotic effect, stimulate fibroblast proliferation, angiogenesis, which we know is really important for bringing in the nutrition and oxygenation, reduce the scar, as it says, it modulates scarless healing, and a lot of anti-inflammatory. And again, these are multiple molecules over here. Now, you'll see a lot of stem cells as you go to different conferences that would be sold and advertised. There will be stem cells taken from fat, from bone, from the person themselves. The issue with the stem cells that are taken from adult tissue, as you can see here on my right, is that just like those or adipose tissue, is that they're already aged and they do not have all the growth factors that you would have in the age zero, exosomes. And so they're not at their peak performance. Just like if I would run right now a marathon, or I would run it when I was 16, it will be a different marathon for both of us. I wish I could run it like I did when I was 16. But the idea is our performance is not as good, and sadly, even our stem cells will not produce as good an exosome. Even though they can produce it, they will not be as effective. So this is the effect. It has lower fibrinogen, fewer angiogenic factors, and fewer immune-regulated proteins. And this shows the mechanism of action, how when it's released from the stem cells, mesenchymal stem cells, this is the exosomes over here, and this is a large image of the exosomes. It basically changes the inflammatory conditions. So M1 macrophages are the ones that are stimulated or released during infection and wound healing. They cause inflammation, and inflammation actually slows the healing. We want to reduce the inflammation because we can control and avoid infection. We want to have the right pH for it to heal well. Also, the other thing it does is increases vasculature, more blood supply, better nutrition, better oxygenation, faster healing. And also it helps the proliferation and the migration of the necessary cells, helping to remodel the extracellular matrix, the ECM. And you can see this is the idea of the wound healing, that it would promote the exosomes. Let me share with you some of the cases. This lovely young lady was one of the first cases that I used exosomes on injection-wise on a patient. She came from the emergency room all in panic after a can of condensed milk exploded in her face. She went to the ER. They provided her with Silvadin, silver sulfadiazine, which is unfortunately the common treatment in the ER. In my opinion, it's already outdated and not the best option for treatment. There's so many better treatment options, but anyway, it's antiseptic. Unfortunately, it also dries the wound and it's not optimal for wound healing. She came to me all scared. This was a second-degree burn on her forehead, glabella, and you don't see it here, also on her nose and her eye. And after 5 days, even though she's dark-skinned patient, it healed without any marks. It's a little dark picture. There's a little light on her nose, but this area over here and the rest of the nose cleared without post-inflammatory hyperpigmentation, which is remarkable. And I used twice injections, one after the other, and she came to me to show the results, which she was ecstatic, and afterwards ended up sending other patients. This was a next patient that I had, and she came 10 days, she's actually a nurse, she came 10 days after a blistering burn from spilled boiled water. And you can see here, this is deep dermis. You can see this is the reticular dermis, and the rest is the papillary dermis, where it's a little more red. So this is why it almost looks like fat, but it's not fat, it's the reticular dermis. And around it you can see the sloughing skin, which is black, and that's where the blisters came off, and the skin is still burnt, but it's still on top of it. I injected her with 400 billion exosomes, and you can see 1 day after that, she's already granulating. It looks much, much better. Look at the color here in the difference. It's starting to shrink. 9 days afterwards, it's like, wait, completely healed? yeah, it looks like it's practically completely healed. There are some areas here that maybe if you zoom in, you could see that it's a papillary dermis still healing, granulating. Oh, this is, about a little over 2 weeks afterwards, completely healed. A little bit hypopigmentation, a little bit loss of color in the area, and this is a little bit area of hyperpigmentation. This is how she came 6 months afterwards for us. Now, of course, we can do some lasers to help bring down the brown, but the issue is she does not have any scarring contraction. There is no itching. There is no keloid formation. The color is pretty good. The healing time is very, very rapid. And there is no need for sutures. There's no need for additional scars, taking split thickness graft or buying some expensive $15,000 skin graft, allograft, and applying on the area. So again, this is H0 exosomes, the beauty of them. Patient number 3 is actually a Mohs patient that I had, and that patient presented to me with a big skin cancer on her scalp. She originally comes from the Soviet Union and was not directly in the path of the Chernobyl fallout radiation, but I see a lot of those cases with very weird, strange, large skin cancers, and I do believe that the fallout is related to that, because in May there is a big parade that they always do for the Victory Day against the Nazis, and they all were forced to go outside and parade. So even in Moscow, when they went to parade, there was some rain, and they didn't realize the rain contained fallout. And the fallout, I've seen patients, multiple of them, who have skin cancer specifically on their scalp, even not so much on their body as much as on their scalp. And I do believe it's related to the uranium causing chronic inflammation, and 20 years down the line leading to skin cancer. But anyway, that's something that needs to be proven, can be proven, but I'm having difficulty finding people who would be willing to look through the pathology just like they look through fossils and try and look at the different products that are in it, like the uranium. So this is a large wound, and here I'm showing you to her because we decided initially to put a skin substitute graft. And you can see here, she's got the skin graft in that area, and she came in and it already fell off. This is when she got the skin graft, it fell off. And the dressing that she had on the area fell off because she, it wouldn't stay on the scalp. It's easy to understand. There's a lot of hair and it has to stay there for a week. It's very, very tough. I mean, you move your head in sleep, even not in sleep, and you just move your head and it starts gliding down. It's very difficult to keep the dressing tight on that area. So what we did here, this is just some Silvidin around the area to prevent the loss of the exosomes when we inject it. We put first a little bit of Vashi, which is hypochlorous acid, to apply on that area, which has a little bit higher pH. We use saline afterwards to neutralize it, to make sure that the pH is more around neutral pH so that the exosomes will work more effectively. And then we inject the exosomes intradermally. And this is, you can see 3 days after the injection. You can already see it's shrunk. This is 7 days after, and you can see it's already granulated from an area where there's an area here to the fascia, fat, dermis. There's actually no dermis in here, but fascia and fat. It starts already to be already dermis, and here the fascia completely healed, and most of the area is granulating with nice dermis. Still some areas are black because she was on blood thinners, and so we had to cauterize extensively, which means lack of blood supply and also impedance of healing. So you can imagine without it would have been even worse. And here you can see her 9 days afterwards. This is absolutely remarkable. I mean, when I saw that, my jaw dropped. This was remarkable. The other thing was, we were wondering, will we get some of the appendigeal structures back? Because if we would put a graft, this entire 5.2 by 4.7 centimeter would be a hairless area. Yeah, you can cover it with longer hair, but with age, as we know, everybody suffers from some hair loss, and this will be aesthetically definitely not pleasing for anyone. So this is the next, this is again showing you for comparison her before, and this is the second day after her 5th and last injection. I decided not to inject anymore and see how it will continue to heal just from that. And this is, you see, April 1st, and this is April, I think it says 23rd here. Yes, 23rd. And let's look at the next slide. And this is May 21st. So this is about 7 weeks after the graft fell off the scalp, and you can see the hair is in that area. The entire wound shrunk very, very nicely, and it shrinks. The strange thing is, look at the shape that it forms. It contracts based on what mobility the body has. We're just using here a Q-tip to move the hair out of the way because it's already covering it so well. So if I would have done a flap on that area, the scar tissue would have led to hair loss. The area would be with significant amount of pain. Most likely it would have anyway had areas of dehiscence and require secondary intention healing. The downtime, the wound care, it would be really, really not something that I would look forward to as a patient to go through. And we always have to think of ourselves as we treat, as physicians, our patients, what would we want done to ourselves, right? So anyway, I think the future is here. The future is exciting. And as Yuval Raphael's song prays, may hope, unity, and peace bless our world. And with that, may we all wish and hope for a new day to come. A new day will rise, like the name of our song. And thank you so very much for listening and for giving me the honor and opportunity to be with you guys, even virtually here today, and to present it. Thank you. Any questions?
Yes, I have.
Yes.
Talking about the maintaining the pH below 7, something like that.
Yes.
Yeah, so I have been doing that in my patient's cases. I have been using the raw diet for some time.
The which one?
Alkaline in the raw diet.
Ah, raw diet, okay.
Like say cabbage, purple cabbage, then cucumber, then radish, onion. All these things I have been using for maintaining the pH, particularly for any type of problem, because I use food as a medicine. I'm not giving any drugs or any chemicals, but I'm using food as a medicine.
I love it. I love it. That's beautiful. That's beautiful. So, can you explain how you use it? Are you using it as a food, or you're applying it topically? You mesh it. How do you do it?
No, as a raw diet, we can take it as it is, maybe in slice form or maybe cut forms or cubes, and it could be used.
I would love to see how you use it. Honestly.
I'll talk to you separately, and we'll talk on that. Yeah.
Very exciting.
Yeah. Yeah. Maybe during my stay in USA, I can visit your university.
It would be an honor. Please, any one of you guys, if you guys want to come and visit, I'm happy to share whatever I've learned, gleaned, and learned from you guys as well. I'm here in Brooklyn. It's 35 West End Avenue, my office. I have an OR. You're welcome to come in. Just you can share my contact, and I'm happy to be helpful.
And I'm in Texas now.
I need to visit you.
Yeah, thank you. Yeah, thank you very much.
Thank you very much. Anybody else? Any other question or no? We're good. Thank you so much. God bless. Have a wonderful day.